And it is our pleasure to have with us today Professor Michael Atkins. He's a medical doctor and he is a well-known expert, especially in melanoma and renal cancer. And he started his studies when he was at the Beth Israel Medical Center, then at Harvard Medical School. And now there he led the program in biology therapy, cutaneous oncology, and kidney cancer. Now he's deputy director of the Georgetown Lombardi Comprehensive Cancer Center and vice chair of the Department of Oncology. He's published more than 500 peer-reviewed articles, and mainly his research focuses on immunotherapy of melanoma and of renal cancer. So as an MD, he also sees patients. So he has a direct contact with the diseases. And so I think he is going to tell us how he developed during all these years and the research and what are the progress ongoing, what we can expect from the novel immunotherapies for melanomas. And I think since Professor Atkins is doing also, as we said, research, so I guess he will tell us also what are the novelties coming from his laboratories, combining with the medical therapy of the patients, and say that for JCMT is a great honor to have you as our guest telling us what is going on melanomas and renal cancers. So welcome, Professor Michael Atkins, and tell us more about you from all your journey in cancer research and medical care.
Thank you, Ciro, for that introduction. So when I think back on my 35 to 40 years of time in oncology and in immunotherapy, in melanoma and kidney cancer, two things come to mind. One is serendipity, being in the right place at the right time, and the other is teamwork. And everything I've accomplished over my career has really been part of a team, and I've been fortunate to be part of some great teams from the very beginning of my faculty years to the present time. And I hope as I go through this journey and some of the things that I think were important discoveries along the way, I make sure I emphasize the people who I worked with to make that happen. So I actually started my career, Ciro, at Tufts University. I actually went there as an undergraduate, as a medical student, did my internship and residency there, was chief resident, did my hematology oncology fellowship there, and then was on staff there for 10 years. So all told, 25 years at Tufts. And I'd like to say at the time that I had never interviewed for a job, which was fortunate at that time. I just went the next step along the way. As I finished my chief residency, I wasn't sure what I was going to do, and I had some obligations to the National Health Service that helped me pay for medical school, and I was assigned to the Texas border, and I was married at the time and really didn't want to go down there, so I converted that to a national research scholarship, which required me to work a couple of years in the lab. And I looked around at the institution I was at and the laboratory opportunities and what I was interested in, and decided that I would ask the HEMONC division whether I could do research in the labs there. And I was fortunate to get into the laboratory of Dr. James Meyer, who purified interleukin 2 when he was at the National Cancer Institute, and then they came to Tufts. And so the first things that I did, even before I started my clinical years of fellowship, was to work on interleukin 2, which is one of the first, if not the first, immunotherapy. And that led to us actually applying for a grant and becoming part of the extramural IL-2 LAC working group, which was a group of 6 institutions, which was formed to reproduce the results seen by Dr. Steven Rosenberg at the NCI with interleukin 2 and LAC cells. And so I was doing that before I had done any of my clinical fellowship. And during my clinical year, I primarily worked on our interleukin 2 studies and our IL-2 contract with the other 5 institutions. And when I finished my fellowship, I decided I would stay on and keep working in that area because it was a cool area that had been just recognized in Newsweek as being the key to cancer.
May I ask you, what kind of tumor at that time were you working on? Was already the melanoma or another one, another type?
When we first started our own experiments with interleukin 2, we worked on all cancers, typical phase 1 study. But when we started to reproduce the work of Steve Rosenberg, we focused on IL-2 treatment for melanoma and kidney cancer because those were the 2 diseases that he had seen activity in. And so within a short time out of my fellowship, Dave Parkinson, who led our contract with the NIH, left the institution, and I was in charge of the contract. And it was the largest grant within the institution, lots of money and a lot of activity, and it was left to me 4 months out of my fellowship. And so I worked with my colleagues around the country. We designed protocols. We tried to figure out how to make IL-2 work better. We tried to improve the therapeutic index by combining it with interferon and lowering the dose, or figuring out how to prevent the toxicity of high-dose IL-2 by giving steroids or giving blockers of TNF or blockers of IL-1, how to combine it with chemotherapy and all those type of things. And we learned that the best way it worked was just as pure IL-2. One of the key experiments that we did, or clinical trial that I led, was to combine IL-2 with chemotherapy under the theory that chemotherapy could cause immunogenic cell death. And so we combined...
Can we give an idea of when was it? In which years are we? So people can figure out how we developed all our ideas.
Yeah, so this was in the 1980s, late 1980s, early 1990s. And so we did in the cytokine working group, we did several different studies trying to figure out how to combine chemotherapy with IL-2. And we eventually developed a regimen that gave them simultaneously and called biochemotherapy. And we saw, and this is very instructive and has really influenced how I think about these things going forward, we saw doubling of the response rate, doubling of the progression-free survival with biochemotherapy compared to chemotherapy. But when we did a large phase 3 trial in the cooperative group comparing biochemotherapy to just the chemotherapy, there was absolutely no difference in overall survival. And so the chemotherapy completely eliminated the efficacy of the IL-2 on long-term survival. And so that has made me I spent a decade on that. That has made me very worried about things that might be combined with immunotherapy that might interfere with the principal effect of immunotherapy, which is eliminating the last cancer cells and being able to produce tails on the progression-free survival, overall survival, duration of response curves, and treatment-free survival. And that has carried through to the checkpoint inhibitors today. Another important thing that we did in our high-dose IL-2 studies was we observed that IL-2 caused immune-related adverse events. We called them autoimmune events. And the first major paper that I published talked about IL-2 induced autoimmune hypothyroidism that was published in the New England Journal. And we said that it was autoimmune in nature, and we had the data to prove it. And we also found that it was associated with response. And so I think that was the first report of immune therapy producing immune-related adverse events. So after working with high-dose IL-2 and the cytokine in the extramural lac working group, we decided to see if we could work on other cytokines such as IL-4, IL-6, IL-12, IL-18. We did the first studies of all of those things and decided to rename our group the cytokine working group. And the field of oncology had moved away from immune therapy, and people were focusing on targeted therapy, identifying mutations in the tumor and how to target them. But we were this lonely group. We got a few more institutions to join us that was still thought that the immune system was the way to cure cancer, and people wanted to be cured. But we couldn't figure out how to get beyond the 15% response barrier. And so we knew from the studies of TILs at the NCI surgery branch that there were T cells in the tumor that could recognize the tumor, but for some reason weren't doing anything. If you took them out of the tumor and grew them up, they would recognize the tumor and kill it, but they weren't doing anything. And we tried to figure out what was causing those T cells from actually killing the tumor. And we needed the work of people like Jim Allison and Toshuko Hanjo and Gordon Freeman to unlock that particular box and identify the immune checkpoints, which were protecting the tumor from the immune system that was there to recognize it. So our experience with high-dose IL-2 led us to first understand that the immune system could cure patients with cancer, and also to understand that the T cells were there but were being inhibited for some reason, and that, I think, kept the field alive while we were waiting for scientists to come up with reasons why the immune system wasn't working. And so around that time, I had now moved to Beth Israel Deaconess and became part of the Dana-Farber Harvard Cancer Center. And we were working on things like targeted therapy and angiogenic therapy and keeping our IL-2 program open. And then I saw that this was a real opportunity to advance the field of immune therapy. And so we got involved in the CTLA-4 studies and the anti-PD-1 studies, and we saw some remarkable results. And when we started to see responses in patients with lung cancer, not just melanoma and kidney cancer, we knew that this was going to be something that was going to make a big change in the way we treat cancer. And it was around that time that I decided, let's move from Boston to Georgetown. My kids had finished growing, finished their schools, and were out of the house. And there were a lot of smart junior people at Harvard who were working with me, like Dave McDermott, and who wanted to have leadership roles, so I decided I had done as much as I could do within the Harvard system, handed leadership roles to them, and moved to Georgetown to try to bring immunotherapy to Washington, D.C., and to other diseases, working with my longtime colleague Lou Weiner at the Georgetown Lombardi Comprehensive Cancer Center. But even I could not have predicted what a big deal immune therapy would become, from a group of people treating diseases for which there was really very little treatment, melanoma and kidney cancer, and for which there was very little interest. It suddenly became super hot. And the studies that we did in melanoma, combining anti-PD-1 with anti-CTLA-4, produced just remarkable results. We were involved in the 4-institution phase 1 trial that showed that you could, in patients with metastatic melanoma, you could produce rapid and deep responses over a period of about weeks, and that you could stop the treatment and have the benefit persist. And so we focused our efforts at trying to, as we've done throughout the career, trying to figure out how best to use the agents that we had. And around 2015, we had BRAF MEK inhibitors available for patients with BRAF mutant melanoma, and we had we had Nivo/Ipi also available, both of which improved the survival. And the question was, which was preferred? And so within the cooperative groups in America, I decided to lead a study to compare targeted therapy to immunotherapy. And because both were about to be FDA approved, and people could have access to both, to look at which sequence was better. And so we launched the DreamSeq trial, which took a long time to actually finish, but there were a lot of people who were participating. And what we showed when the data was actually unblinded was that giving immunotherapy first had a statistically significant and clinically meaningful 20% improvement in 2-year overall survival, and that it increased to 25% with more time. And the reason for that was that immune therapy was helping all the different subgroups of patients more than targeted therapy. That although the response rates were similar, the responses were much more durable with immune therapy. That immune therapy worked in the central nervous system, while targeted therapy did not work well in the central nervous system. And targeted therapy worked well after immunotherapy, while immunotherapy did not work as well after targeted therapy. Something about targeted therapy changed the tumor microenvironment to make immune therapy not work well in this second-line setting. So that was a very important principle that we, I think, learned in melanoma, and now we're trying to apply to kidney cancer. Yes, sir.
Yeah, this is very interesting what you are saying, because on one side, okay, in your clinical trial, of course, targeted therapy was done in the subgroup with the BRAF mutation, whereas you were treating, say, the population regardless of the BRAF mutation, right?
No, we were treating only the BRAF mutant melanoma.
So the subgroups were similar. Yeah. So in this case, even though you had the BRAF mutation, the immunotherapy was giving a better outcome, say.
Yes,
And the other thing, very interesting that you said, is that if you first do the targeted therapy and then the immunotherapy, the outcome is not that good as if you would use it at first. So this tells us that in the cancer, when we target a subpopulation of cancer cells, we change the microenvironment so that even cytokines and immune response change, correct?
that's correct. In contrast, when you give immune therapy, you're not, you're trying to get the immune cells to kill the cancer. And if it doesn't work and the cancer grows out, it's still being driven by that driver mutation. So you still use the targeted therapy. So the sequence matters. And so we have applied that to kidney cancer, where we did a lot of work when I was in Boston trying to figure out what happens when you give VEGF inhibitors to patients with kidney cancer. Because they have a VHL mutation, which causes upregulation of VEGF in the through HIF upregulation in the absence of hypoxia. Those tumors typically are growing purely under VEGF and are not hypoxic, and they don't need to have other angiogenic factors to drive their angiogenesis. And so when you give a VEGF inhibitor to a patient with kidney cancer, the kidney cancer it causes an infarction in the tumor because it kills the blood vessels. So by day 3, there's no blood vessels in that tumor, and the tumor has trouble surviving that hypoxic situation. And eventually, over time, there's angiogenic escape where other pro-angiogenic factors besides VEGF come in and restore the blood supply for the tumor, and the tumor starts to grow again. So we looked at that. Yeah, we looked at that and thought, this is not a good time to be trying to maximally activate the immune system. And so the combination studies of VEGF inhibitors and anti-PD-1, which was the rage, similar to the way we wanted to do chemotherapy plus IL-2 back in the 1990s, was showing great results in terms of response and prolonging PFS. But we were trying to focus on the tail of the survival curve and the PFS curve and see how stable it was. And we couldn't see that a stable curve. And when you stop the VEGF inhibitors, the disease started to grow. And so we were interfering with the immune response, the value of the immune therapy, by not eliminating the last tumor cell. We were putting a drag on the immune response. And so learning from our melanoma experience, we've pushed for giving better immune therapies up front. That was the way to increase the cure rate for kidney cancer. And so we've let me just finish this point. So we've then worked at trying to identify who responds and who doesn't respond, and identified mechanisms of resistance to the immune therapy that led us to propose different ways of giving immune therapy, or different immune therapies in the frontline setting that we're currently researching. And your question, if I have...
Yeah, because it is back to the mechanisms you were investigating. My question is it there something related to immunogenic dormancy, angiogenic dormancy of your tumor, so that you said when you stop inhibiting angiogenesis, then they regrowth, or when you stopped the immunotherapy, they would regrowth? So I'm wondering if dormancy, the tumor dormancy, is part of the problem you have there for the relapse.
Yeah, I wouldn't have called it that, but because we look at CAT scans and we assume that what we're looking at is all tumor, but what's in what we see on an X-ray is not all cancer cells. It's a bunch of things, and we can't
Ah,
distinguish how much of it is immune cells, how much of it is tumor, how much of it is stroma. And
mm,
so when the tumor shrinks, I think it underestimates how much tumor death there is. And when it starts to grow, it may take months before you actually see that growth visible on a scan. So what I think the problem is when you're giving VEGF inhibitor with anti-PD-1 is you're not fully activating the immune system and not eliminating the cancer cell. And the way to get rid of the cancer cell probably happens in the first 12 weeks of therapy with immune therapy. And after that, you're just sort of maintaining stuff. And it's by the time you get out to a year or two, if you stop the VEGF receptor TKI, that's the only thing that's keeping the tumor from growing. And when you are giving VEGF inhibitors, you're causing hypoxia and increasing the level of VEGF in the blood. And so when you take away the block, the tumor starts to grow. And so that is something that's very important that we've learned in melanoma applied to kidney cancer. And the general observation that I would summarize is, I think it's the driving point of my career and a message that I want to get across, is that when we're treating cancer, we should try not to turn cancer into a chronic disease, but we should try to cure the cancer. And the best way to cure the cancer is through immunotherapy. And the best way to give immune therapy is to give the best immunotherapy that you can as the initial treatment. And that's what we're trying to, that's what we showed in melanoma. Now we're moving things even further into the neoadjuvant setting. And that's what we're trying to show and convince the GU oncologist in kidney cancer that the same is true in kidney cancer. And hopefully have some influence on the treatment of some other cancers where it's become standard to give chemotherapy with anti-PD-1 instead of potentially focusing on giving the best immune therapy first and then rescuing with chemotherapy.
So again, what you are proposing is to fight cancer, to start with immunotherapy first, and keep the other weapons for, say, a second round of therapy.
If necessary, and hopefully it won't be necessary.
Okay, but in the tumor microenvironment, you don't expect that some myeloid-derived suppressing cells would come up and then blunt the immune response there.
In some tumors, that's clearly the case. And so we're working on frontline tumor regimens that might take care of the other mechanisms by which tumors escape the immune response, which includes immunosuppressive factors in the tumor microenvironment, such as Tregs or myeloid-derived suppressor cells, and giving combinations to the right people in the front line that can deal with those other mechanisms of escape, we believe is the way to go.
When you talk about immunotherapy, are you talking still focusing only on interleukin 2, your first love, or you are now comprising a range of interleukins?
Yeah, we're not giving interleukin 2 much anymore, although I think there's some new interleukin 2s that are being developed through engineering that can activate T cells directly in the tumor microenvironment that may play a role. I'm primarily talking about checkpoint inhibitors and things that activate factors that are suppressing those T cells that we know recognize the tumor in the tumor microenvironment. And then increasingly, some of the new therapies that bring T cells to the tumor microenvironment, such as TIL cells or T cell engagers or modified TCRs, where the tumor itself has is either not immunogenic enough or has developed ways of excluding T cells from the tumor microenvironment, and we can potentially fix that defect by giving by re-engineering T cells and bringing them to the tumor microenvironment to do the job. Yeah. Well, people have often asked me, particularly during the IL-2 days, why melanoma and kidney cancer and not other cancers? And I think the reason is because kidney cancer is very angiogenic, so the immune system has an opportunity to work. And melanoma doesn't have much in the way of a fibrous stroma. It too is angiogenic, and the antigens are there in abundance from damage from the sun, and the immune cells can get active. And so the melanoma's principal way of protecting itself is by putting up PD-L1. And so if you take down that particular defense, the immune system can work. And that for tumors like pancreatic cancer or carcinomas, which have this firm fibrous capsule and tumor microenvironment, I think in order for immune cells to work optimally in that setting, you've got to figure out a way to drill through that fibrous stroma to actually get at the tumor cells. And those are things that colleagues of mine are working on.
Mm-hmm. So that's a good message again to say that indeed the tumor microenvironment makes a pretty major role besides oncogenic addiction, as we said, like for the BRAF in the melanoma, but still the tumor microenvironment makes the difference whether that oncogene will be truly the drivers, or the stroma is somehow trying to keep the cell under check.
Yeah, well, I think the message is that all cancers to survive have to figure out how to escape the body's immune system. And some do it in different ways. Tumors like pancreatic cancer build up a fibrous stroma that keeps the immune system out. Other tumors have myeloid-derived suppressor cells and immunosuppressive factors that overwhelm the T cells that are there. Others don't present antigens at all. Others outgrow the immune system, like Burkitt's lymphoma. But fortunately, many tumors use as their last line of defense putting up PD-L1 as a way of protecting themselves from activated T cells, which have recognized them and are at the gate ready to kill them. And because of that, and that's true in maybe more than half of patients with melanoma and close to that in kidney cancer and several other tumors, we can restore the activity of that immune system and finish the job very quickly with just antibodies. But for those other tumors, we're still working on ways to break down those defenses.
And one more thing, you were mentioning about angiogenesis, but of course that was a systemic treatment with the inhibitors, right? So we cannot keep on going for a long time with that.
Those were VEGF inhibitors, which were given systemically, which work primarily on the blood vessels, which is why we call them anti-angiogenic rather than targeted therapies.
Mm.
And people can stay on them for years, but it's not great for the body to stay on those for years, but it's better than having your cancer grow.
Okay, so still it is working, you mean? Even, okay.
Till the angiogenic escape kicks in, which happens quicker in some patients than others, but for those that are primarily dependent on VEGF and have a fairly differentiated tumor, it could be years before the tumor starts to grow, but they almost always escape.
Okay. So one more thing, I think you mentioned about immunogenic cell death. This reminds me the work done by Guido Kroemer at that time describing this. And so that was the time you were also working on immunogenic cell death.
Right. We thought that certain chemotherapies could cause immunogenic cell death. And we would want to combine those with immune therapy. But I think immunogenic cell death is primarily something that is seen in mouse models.
Mm-hmm.
I don't think it's that relevant to patients with cancer because patients with cancer have had those cancers often for years, and the cells have been dying for years, and they've already auto-immunized, while a mouse may have had that cancer for a couple of weeks and hasn't immunized. And if you kill some tumor cells, that's a good way of presenting new antigens to the immune system back. And so it's chemotherapy causes dividing cells to die. If you want the immune therapy to work, you want it to see the cancer, become activated, divide, and conquer. But if you've got chemotherapy on board, those cells are going to die when they try to divide. And so that limits the ability of the immune therapy to be fully active.
Yeah, of course. Mm-hmm. I understand. But you said also one important thing that unfortunately not all what we learn from the mouse can be translated into the patient because the natural history of the cancer makes the cancer different from what you induce in the mouse. So there is a selection, a natural selection during the natural history of the cancer, which is not reproduced when you artificially induce the cancer in few weeks in the mouse. That's
particularly true for immune therapy. It may not be as important for tumor-targeted therapy, where you can
exactly. I agree because
models and where the immune system doesn't play any role in the activity. But for immunotherapy, we don't have really good mouse models for what we're trying to do in humans. And even the genetically altered models, they're immune competent and the tumor's growing, but they're manipulated tumors that aren't like the tumors that you get in humans from cigarette smoking or from
because that develops in 20, 30 years, and the tumor microenvironment changes day by day to adjust, adapt, and so when you come up with the diagnosis is something different than what you can try to reproduce there. As you said, for checking the targeted therapy, it works, but if you have to work through the tumor microenvironment, that is different, definitely. Well, I think you gave us a nice picture of what is going on in your laboratory and in general for the therapy of melanomas and renal cancers. And We thank you very much because I can see you are tired and your voice is pretty gone, but you did a great job and you explained very clearly what is going on in cancer research.